Welcome to Aetcm, the emergency medicine channel. Today we will be discussing about an upper GI bleed case. For the discussion, we have Dr. Priya. She is a clinical assistant professor of Department of Gastroenterology, and we have Dr. Sabarish. He is consultant of emergency medicine. Can we begin?
Yeah, please.
Sure.
A 70-year-old male patient was brought to ER with complaints of 2 episodes of hematemesis and 5 episodes of melia since last 3 days. Initial 10-second assessment, patient was conscious, oriented and obeying commands. Airway was patent. There was no pooling of secretions or any vomitus. C-spine was normal. There was no hoarseness of voice and he was able to complete one full sentence. Breathing, his respiratory rate was 18 per minute and saturation was 96% in room air. Air entry was bilaterally equal and chest exertions were normal. Circulation, his heart rate was 95 per minute and blood pressure of 120 or 70 with a map of 83. All peripheral pulses were felt equally and bilaterally. Disability, his GCS was E4, V5, M6 with pupils of 2 mm bilaterally equally and reactive. And exposure part, his temperature was 98 degree Fahrenheit with a GRBS of 170 milligram per deciliter and hypothermia was prevented by blanket. At this point, his airway and breathing and circulation are stable.
Yeah.
So
Okay.
I inserted 2 large bore IV cannula and his blood samples were taken and blood was arranged for blood group and cross matching because he presented with hematemesis and
Okay.
melanoma. VBG was taken, baseline VBG was taken, which was showing a pH of 7.380, PCO2 of 40.5, bicarb of 23.4 and lactate was 2.1.
Okay.
Our VBG will show hemoglobin, which was 7.7.
Okay.
Sample history, he doesn't have any allergy. He was a ethanolic since last 20 years and he was diagnosed to have CLD 1 year back. Current CLD child score is B and MELT 8.
Okay.
And he's a diabetic and there is no history of any malignancy or anything. He is on metformin and glimepiride.
Probably you can add if there is a previous endoscopy, anything is there, probably you can add that.
This was his first presentation.
Okay.
With the GP.
Also, like whenever you say about ethanol-related CLD, is he abstinent?
Yes, since the last 1 year, 1 year back he was diagnosed to have CLD and after that he stopped.
So this is the first episode of bleed after he has been abstinent.
He is taking metformin and glimepiride twice a day. He was on a propranolol 20 milligram once a day.
Once a day.
Yeah.
Okay.
Last meal was 1 day back. Patient had 3 to 4 episodes of black tarry stools since the last 3 days, but he remained at home. Since the last 2 days, 2 days back he had 2 episodes of hematemesis, around 100 to 200 ml each, and for which he was taken to an outside hospital and his hemoglobin was around 8 and there he had 1 more episode of melena and he was started with pan-octreotide vitamin K ceftriaxone and referred here for endoscopy.
Okay.
There is no history of any abdomen pain, any retching or any syncope history, and no history of any reduced urine output or altered sensorium.
Okay.
Head to foot examination. General examination, he had pallor.
Any medication history you want to mention?
We have to specifically ask for NSAID intake and aspirin, antiplatelets, aspirin, anticoagulant. That was not there.
And you've already mentioned, but in all cirrhotics, whether they're taking propranolol is very important to mention. Because even when you start talking about their pulse rate, you cannot look for tachycardia when you are assessing the severity of bleeding in a patient on propranolol. So it can be a little, it can mask the tachycardia.
Okay.
There was no icterus, clubbing, cyanosis, lymphadenopathy or edema. There was no peripheral signs of CLD seen. There was no spider-navel prostatomegaly or parotidomegaly or any gynecomastia. And there was absence of hair in the axilla and the chest. Per abdomen examination, per abdomen was distended. There was no scars or sinuses. External genitalia and hernial orifices were normal. Palpation, abdomen was soft, non-tender, or there was no fluid thrill. Bowel sounds were also present. Central nervous system examination, patient was conscious, oriented.
No shifting dullness?
No, ma'am.
So the distension was just gaseous distension?
Distension was there, but there was no shifting dullness or anything.
Okay.
central nervous system examination was within normal limits and he didn't have any flaps. And other system were within normal limits. So we have a impression as we have a CLD child B patient with a first episode of upper GI bleed. The etiology of CLD was ethanol related and he's abstinent since last 1 year. So it can be a probable variceal bleed.
Okay.
So we will be doing a scoring system in the ED.
So before you get to the scoring system, based on your clinical examination, what are all the points that are going to be vital for you when it comes to how deciding what medication to start the patient on? What of the, you gave a whole list of his head to foot examination per abdominal. Are any of them particularly crucial for you to know? Like for example, you said that there is no ascites. Does that change anything in your management when it comes to what you're going to start the patient on? Somatostatin analogs, you will start them on anyway, because any patient, what is the role of the somatostatin analog?
Octreotide and all, it causes vasoconstriction of the portal.
Essentially, you're attempting to reduce the portal pressures. So, irrespective of whether there is any other form of decompensation of cirrhosis, the patient is bleeding because of high portal pressures, and you have to reduce the pressures. So, either octreotide or terlipressin, or you will anyway have to start that. But does the presence of ascites change anything else in your management? So basically, I guess you'll be getting to that, but regarding antibiotics in a patient with upper GI bleed, normally we don't give antibiotics if you're suspecting a non-variceal bleed. So ulcer bleeds and all, it's not part of the requirement to start them on antibiotics. Whereas in a cirrhotic, you need to start them on antibiotics. Why is that?
They are highly prone for SBP.
They are highly prone for SBP. So if you have a patient that is dry, not decompensated, technically speaking, GI bleed until recently was not even considered as a decompensation of cirrhosis. It was jaundice, encephalopathy and ascites. So if it was a compensated cirrhotic that comes with a GI bleed, what you have a high incidence of is decompensation. So that will tip the scale. But if the patient comes to you dry, then we say you need start only, like for example, cefotaxime. Some people used to even start, I think previously the guidelines said you need to start on penicillin. That was thrown out. Then it became cephalosporin. So cefotaxime, ceftriaxone is more than enough to start if a compensated cirrhotic comes with a upper GI bleed. But what if they have ascites? So you are afraid that the compensated cirrhotic will decompensate because of a bleed, but if a patient is already decompensated with ascites, there is more than a 60% chance that that bleed can precipitate a SBP. So it is not going to be enough to start them on something like cefotaxime or ceftriaxone. You want to start them either on cefoperazone sulbactam. Usually that's what we start here. But there are centers that even will consider piperacillin, tazobactam or higher antibiotics. That's based on what your local prevalence is of SBP, the local SBP profile. So that is one thing in the clinical examination why it's important to know do they have ascites or not. Anything else? Other than, so one of the things in your clinical examination that you should note ideally that's going to affect what you start the patient on is ascites. Anything else?
Patient with encephalopathy, then
so flaps. Now technically speaking, up to grade 2 hepatic encephalopathy, we don't need to intubate them for an endoscopy, but anything beyond grade 2 we have to intubate the patient even if they are otherwise hemodynamically stable. It's, you'll have to be pulling out clots and you need to have their airway protected, otherwise it's not safe to go in for the endoscopy. Anything else from clinical examination?
That should be it for now.
That's it.
Yeah.
Yeah, that's fine.
So this patient was kept NPO, and he was started on PAN infusion. PAN 80 milligrams was given stat, and followed by 8 milligram per hour infusion was started. And since he's already a diagnosed case of CLD, it might be because of a variceal bleed. So he was started on octreotide. So octreotide was 100 microgram was given, followed by 50 microgram per hour infusion was given, ma'am. And he was also given a prokinetic perinom was also given.
Okay.
And he was started on Magnex, that is cefoperazone sulbactam was started. Then he was also we have sent for the basic lab investigations also. So basically it was showing a total count of 6.53, and his hemoglobin was 6.7, platelet was 120, and other electrolytes within normal limits, and his bilirubin was 0.52 with a direct component of 0.22, and albumin was 3.4, and globulin was 2.4. And SGOT, SGPT was less than 30. And his RFTs also was within normal limit with an INR of 1.14.
Okay.
So at this stage, this patient is in a compensated CLD with the upper GA bleed. We have other things we have already arranged is a hemoglobin was blood was arranged, and he was transfused with 1 pint BRBC, because if at all we have to keep a hemoglobin more than 7 for any patient, and if the patient is having any CAD history or anything, at least a hemoglobin more than 8 should be kept.
Does that rule also apply in this particular case?
This patient is having ongoing bleeding.
Okay.
So we have to if at all there is a ongoing bleeding with instability and all, we have to transfuse even before the drop before the hemoglobin drops more than 7, less than 7.
Yeah. So there is a slight exception. This was 6.8, right?
Yeah.
So I mean 6.8 is too low. Anyway, you have to transfuse. Is there an upper limit of the HB for a patient with a portal hypertensive bleed?
I'm not sure.
So unlike all non-variceal bleeds where in fact if there are a CAD history, one of the common bleeds you get are ulcer-related bleeds secondary to echosporin and all these things in patients with CAD. You want to keep the HB as high as possible. We say it should ideally be above 9. But in liver cirrhosis, until the endoscopy is done, you actually want to keep it between 7 and 8. Just because the more blood you give is going to increase the portal hypertension. So often what happens with these patients is their pressures become high, reach a breaking point, and they bleed. And because the pressure comes down, it's decompressed. It's a decompressing bleed, right? So then they will not bleed for a little while. Gradually the body will, replenish itself, or we give blood transfusions. Again, the pressures go up, it'll bleed again. So a continuing bleed for portal hypertension is unusual, unlike an ulcer bleed. Ulcer bleeds or bleeds because of coagulopathy or whatever are continuous bleeds that whether you increase the hemoglobin or not, they are going to keep bleeding. Whereas portal hypertensive bleed is an intermittent bleed every time the pressures reach that breaking point. So in a cirrhotic patient, you want to give them PRBC definitely, but we just need to keep it between 7 and 8.
Yes.
Once they are transfused, once the endoscopy is done and they're banded or glue injection is done according to wherever the bleed is, then you can replenish give again PRBC 1 or 2 pints so that you get to 9 or whatever you're aiming at based on the age and comorbidities of the patient.
So this patient was given 1 pint PRBC transfusion, and he was taken up for OGDscopy, ma'am. Since he was not in encephalopathy and his airway was protected, so airway was patent. He was not intubated, and OGDscopy was done in the OGDscopy room, and it was showing a grade 2 varices with red color sign present.
Okay.
And it was banded, ma'am.
Okay. What does this red color sign signify?
Rebleeding risk.
Yes, it means that that's a thinned out part of the vein. So there is somewhere that it either has just broken and covered again, or it is going to break in the near future. So RCS is a sign of, even if you're not seeing active blood anywhere, if you see RCS, you should go ahead and ban the Varix.
Following which his hemoglobins were monitored, ma'am. It was always above 7, and we never needed to transfuse any more blood. So that was the case, ma'am. And he was discharged within 3 days.
Okay. A couple of things. So when the patient came in, one of the initial medications that you started was pantoprazole infusion. So what is the role of pantoprazole infusion in this particular case?
Usually pan infusion is ideally required in peptic ulcer bleeding and all. In variceal bleeding, it can control the it can reduce the bleeding. Rebleeding risk can be reduced, ma'am.
Okay.
And if we keep the pH of the stomach less than 6, that will help in healing also. I mean, reducing
more than 6.
More than 6. More than 6.
More than 6, yeah. Guideline wise, we don't need to start a variceal bleed, a confirmed variceal bleed on pan infusion. You need only give 40 milligrams of pan IV BD. But that being said, you can never be completely sure that there is no ulcer, because cirrhotics are more prone for ulcers. Alcoholics are more prone for ulcers. So we advise to put them on an infusion. You're correct, you should keep the pH above 6, but pan BD would also reach that level. However, because you cannot be sure that there is no ulcer until you do the endoscopy, we start them on pan infusion and stop it as soon as the endoscopy is done if it is definitely a variceal bleed. You also mentioned about giving perinome. Is there any particular reason why you would prefer perinome over, say, ondansetron or something else?
Perinome, along with the antiemetic activities, it is also a prokinetic.
Yes. So it helps for the endoscopist to see what they're doing. So it makes the world of a difference. It's actually not part of a guideline because therapeutically it doesn't matter which one you give. It's purely for the sake of the endoscopist that you are giving perinome. But the quality of management changes so drastically by giving a prokinetic that it's more than anything else, we insist on the prokinetic being given. So that's something to keep in mind. The last thing was octreotide you had mentioned, no? Is there any particular difference between giving octreotide or terlipressin? Or is any one preferred over another?
Cost-wise issues are there, ma'am. So terlipressin is much more expensive, and octreotide also will be having the same action. The ideal dose is 50 microgram stat dose and 25 microgram per hour infusion.
But we give it at a higher dose. But apart from the cost aspect of it, is there any other aspect?
Other than infusion?
See, technically when you give bolus doses of terlipressin, your effect is more than the octreotide infusion. So when you have a very massive, severe crashing patient, if it is purely because of a portal hypertensive bleed, actually terlipressin is better. But are there issues of giving terlipressin over octreotide?
It can cause peripheral vasoconstriction.
Yes, there is a major issue when you give it at those doses of peripheral vasoconstriction. If the patient is elderly, patient has CAD in the background, this could precipitate a cardiac event in a patient who's already hypotensive with severe anemia, active bleed. So we do use terlipressin actually over octreotide when it is a very life-threatening bleed in a patient that's, let's say younger than 40. They've come with a massive variceal bleed. We tend to prefer terlipressin over octreotide for that initial bolus instead of octreotide. But like you said, this particular patient, he was at the moment he was stable. There was no active bleed at that moment, even when we had done the endoscopy. So in all such patients, octreotide is more than enough. But theoretically, there is a benefit of using terlipressin over octreotide for certain cases.
Okay, suppose just extrapolating this scenario, the patient has come with an ongoing bleed, hypotensive, and you need to intubate. What are the key things you are going to take care when you are managing the AV and AJ bleed?
So there is high risk of vomiting and aspiration, so that should be considered. And if at all before intubation, we have to keep the patient in a proper position, and if possible, we will have to sedate, paralyze, and prevent maximum aspiration as possible. And during intubation, as we do for an intubation in a hemoptysis patient, we have to do a salad approach. That means a suction assisted laryngoscopic and airway decontamination should be done. And it should be
And usually full stomach patients, so hyperventilation should be avoided. Because again that can lead to
back ventilation, not to go for a very rigorous hyperventilation. No, you should not be doing it. Head up position and salad approach. Any role for Ryle's tube?
Ryle's tube wise, if it is a variceal bleed, and if already this patient had a previous banding and all, that can injure the
earlier there used to be RT insertion had a role, sir, but these days it's not recommended for an RT.
It's contraindicated now.
Yeah, it's not used now.
It's contraindicated because even if you've not had a variceal bleed before or a recent banding, just the process of putting the RT can rupture a varix. And even if it is a potential ulcer bleed, all you need is to touch the top of the ulcer and you can precipitate a bleed if it had just, covered over. So we see that a lot when a patient is referred from outside. They are referred with an RT in situ. But preferably it is good not to put an RT in any patient with upper GI bleed. It's always better to just go ahead straight and protect the airway and then let the RT be placed, if at all, only after upper endoscopy. Are there any scoring systems for upper GI bleed in the ER? How do you do that? What are the different systems?
We have the Glasgow-Blatchford score, ma'am. It is basically to look for the severity of the upper GI bleed, and if the score is less than 0, that means it is a criteria to discharge the patient. And as the score worsens, that means this patient needs some medical intervention to be done. So this patient, the score was around 12, so he requires a medical intervention. And others.
What are the various criteria looked at in that score? Do you have an idea?
In that we will be looking the hemoglobin, ma'am. We will be looking the blood urea nitrogen. We will be looking the sex of the patient, then heart rate, then past history of any hepatic diseases, any cardiac comorbidities or syncope history. That will be considered in GB scoring, ma'am.
So that's the problem with the GB scoring, is that you need even the urea. At least if it was just the CBC, you can do immediate CBC can be estimated and you can make the score. Here you need urea. So there is a slight, not that long, but there is that slight time factor. What about the other scoring systems?
Rockall scoring system is there. In that, there is a pre-endoscopic and post-endoscopic scoring. So it takes into consideration about the age, diagnosis, the comorbidities, and the previous endoscopy findings. These will be considered, and it will estimate the mortality of the patient before during the endoscopy and all. And after the endoscopy also there is a Rockall scoring system that is also finds the mortality and the risk of rebleeding.
Okay. Any other score?
We have the AM65 score.
That can be done immediately as when they come. What is taken into account there?
In that we will be considering the albumin, the INR value, the mentation of the patient, and the shock. BP, systolic BP less than 90 will be considered, and the age more than 65. So if we are taking albumin less than 3, INR more than 1.5, altered mentation, and systolic BP less than 90.
So take on the timing of endoscopy in GI bleed.
Within 12 hours.
Yes,
Early endoscopy means endoscopy within 24 hours. So that will be done if at all the patient is having an ongoing bleed, or if there is any hemodynamic instability, or even after blood transfusion, if the hematocrit is not improving, this patient requires an early endoscopy within 24 hours.
Actually, why do we even say that there is a need for late endoscopy? Like, is there a benefit of that at all? It's only for visualization.
Okay.
Literally, that's the only reason why you stabilize. You give some blood and you stabilize, and basically the endoscopist is waiting for the stomach to be emptied. Otherwise, there's no real benefit in waiting for the endoscopy in that, if you look at it that way. So, in an ideal situation, actually, they are moving the concept of early endoscopy to endoscopy in the ER. That is what is actually advised. Because the earlier you do it in an ongoing bleed, you have that much of a higher chance of the patient having the outcome is obviously going to be better. So there is actually a role. This waiting for endoscopy now is just slowly starting to fizz away, where we are not going to really prefer that. As much as possible, you give prokinetics to the patient, stabilize the airway, very, very important. And as soon as the airway is stabilized, you do the endoscopy. There's no point in really waiting. One other thing I wanted to ask was, you had mentioned when the patient came, you did an ABG. So what are the important things to look at in the ABG when you have a case of upper GI bleed, especially varicose?
We have to check the metabolic status of the patient, the lactate, and we can see the hemoglobin also.
So what does the lactates signify? Anything particular?
Ongoing bleed, lactate will be elevated, and perfusion.
Is there any particular cutoff that says they will have a much higher mortality? So they say that if a patient has a lactate of above 7.4, that's the cutoff. There are a couple of different papers. Everything is between 7 to 8. That's basically ranges. Our own study done here was 7.4. A very large study, I think, published in hepatology was 7.6. But there are different, it's all that range. Even if they appear stable, those patients should be put in the ICU even after their banding for a 24-hour period, to see if their metabolic status is going to improve. That's actually something that we were also looking to study, like the follow-up of that, taking that 7.4 and seeing if they really require ICU stay. But as it stands right now, yes, lactates, exactly what you said, that's what it signifies. But even the number value is important, because a lot of times, I'm sure you must have seen, the patient may appear stable. You band them, but then they suddenly decompensate and they do much worse. So one of the things we look at is that lactate level. If they are, like this patient is 2 point something, 2.4 or something. If he's completely stable, you can monitor him for 24 hours and then he can go home. Whereas if they have a higher lactate, you have to be very careful. Ideally, we put them in the ICU for 24 hours.
So let's assume endoscopy was done and the patient still continues to bleed. What would be the next appropriate step?
Maybe he's having a rebleeding there, or some point was the visualization might not be adequate, so that they couldn't band everything. So such cases, depending on the hemoglobin drop, we might have to take him for a repeat endoscopy.
Okay.
What is this SB tube?
That is sense taker
Blakemore tube. What is it?
It is basically to reduce the bleed. That means if we are not going for an early endoscopy, it can reduce the bleeding. That means that is basically to stabilize the patients and to control the bleeding. So it is having that is basically an advanced type of a tube which is placed through the mouth. For placing this tube, we need to make sure that the airway is secure, and it is basically having an esophageal balloon and a gastric balloon and a gastric suctioning port also. So we will be inserting that. We will be inflating 50 ml of air into the gastric balloon, and we will be checking the position of it, and through an X-ray.
Through an X-ray. Is there a way to do it that does not require any X-ray? So you've placed the tube inside and you have inflated air into the gastric balloon. Then what do you do to confirm where you are?
As we do for a Riles tube, we can do.
Basically, what is the purpose of these two balloons? Tamponade.
Tamponade.
Exactly. So where are you tamponating?
At the esophageal, gastroesophageal junction.
And what are you tamponating there? The gastric varices. So there are two major sites of variceal bleed. You have the esophageal varices, obviously more common, but you also have the gastric fundal varices. That is actually a more catastrophic bleed than the esophageal varices. So you are putting in the tube deep, you put the tube all the way in, you inflate the gastric balloon, and you don't actually need any X-ray for an SB tube. You just pull the tube back, and when you feel the resistance, what does it mean? That gastric balloon, so you've only inflated the gastric balloon, not the esophageal balloon. So you pull it back, and when you feel the tug or resistance, then you know that the gastric balloon is now stuck at the G junction. And your assumption is that good, now it will tamponate the gastric varices if there are any. So once you feel that tug, then keeping that slight pressure, you then inflate the esophageal balloon. There is a small space between the two balloons, so that will hold at the G junction. The esophageal tube will tamponate any lower esophageal varices, and the gastric balloon will tamponate the gastric varices. So that is actually something that is put by the ER doctors, need not be put by a gastroenterologist or anything. When there is delay for endoscopy, patient is bleeding out, there's no time to eat. Sometimes you have such massive bleeds that there is difficulty even in intubating the patient. It's just continuously bleeding. Such patients, you quickly secure airway, put in an SB tube, and then you have that time to transfuse and wait for the endoscopist to get everything ready and come. Is there a risk for the SB tube? What's the problem with the SB tube?
It can cause erosions, pressure necrosis.
Pressure necrosis, which is why you cannot put the SB tube more than 8 hours is a cutoff. You should never have to wait that long. Maximum 1 or 2 hours until an endoscopist can come. But that's something that is done usually from the ER. It's important to know that there is an option like that. Now we have these metallic stents, self-expanding metallic stents. The particular one is called a Danny stent. And instead of putting this SB tube, you just leave this stent and let it expand and sit there. And you hope that, if you wait 24 hours and let the bleeding kind of control itself, then you can pull it out and do the EVL. So that's another thing that endoscopists do. Sometimes the whole field is so full of blood, you cannot see. This EVL is endoscopic variceal ligation, is essentially you're tying a rubber band around it. But you should be able to see the veins in order to tie anything around a bleeding vessel. So when you have such severe bleeds, then you have to, we put in this particular stent called a Danny stent.
Any specific thing? The patient has already undergone an ligation and again comes with bleed. Any specific things you are looking for? Anything secondary to banding or
Pressure.
post-variceal banding ulcers, anything?
Yes, sir.
There's two aspects. One is, if you've not looked carefully at the stomach and then done your banding, by doing a banding itself, you can cause the gastric varices to explode. So that is one very dangerous cause of post-EVL bleeding that happens within the first 24 hours. Right away, you will have that thing break and bleed, which is why you might have seen we literally turn the patient in all sides, right lateral, left lateral, trying to see if we can see the fundus. So that's one cause. The second thing is the delayed post-EVL bleeding, which is actually equally dangerous, because when the point of the EVL is that you are suctioning in the loose vein, tying a rubber band, that will only remain there for about 72 hours at the most, and then it sloughs off. And the natural healing process will lead to a big ulcer that forms there. Now, if you have really only suctioned in the vein, the ulcer will not be too deep. But when you are not able to see and your suctioning is quite forceful, you actually suction some of the submucosa of the esophagus also into the band. That will also slough off. Whatever is banded will slough off. And you are left with something called post-EVL ulcers, which in the background of the coagulopathy that these patients are anyway going to have, you can have very, very dangerous bleeding. And you cannot band them again because all the loose tissue is already gone. So we do sclerotherapy for those patients. There's also hemospray, which is not really so useful, but in desperate times we use it. And then you have this Danis stent. So those are some of the options when it is a post-EVL bleed. How do you put an RT post-EVL?
Endoscopy guide.
Yeah, you have to put a guide wire under vision between the bands. You have to place it. So one thing we often see patients getting, like I've seen from a lot of places where you'll do the EVL and then they are not able to feed the patient. They may be encephalopathic. They may be on a ventilator. So then they immediately put in the RT. So placing an RT post EVL is very dangerous. It should only ever be done under endoscopic guidance.
I think we covered
I think
most of it.
nothing
No?
else, no?
Okay, it was a good presentation. Thanks.
Yeah, it was good. Thanks.
Thank you, ma'am.